Grey County. The opinions expressed in the following programs are those of the participants and do not necessarily reflect those of Rogers nor Rogers TV.
Hi, and welcome to Politically Speaking. I'm David Shearman. My guests today, and we have three, which is really easy to do in this particular setup, because I have the Warden of Grey County, Brian Milne, who is also the Mayor of Southgate. I have Kevin McNab, who is Director of Paramedic Services, and Heather Prescott, who is a nurse practitioner responsible for the Supportive Outreach Service, which we've talked about before on various programs, but we're going to take a bit of a deep dive into it. So, Heather, Kevin, Brian, good to have you all here with us on Politically Speaking today.
Thanks for having us, Mark. David? I see all the names on the screen there, so I picked one.
That's okay. That's okay, Brian. We're good. We're good. Anyway,
it gets better from here.
It always does. It always does. Now, let's talk. We're going to talk primarily about the supportive outreach services here in Owen Sound, but also in Hanover. And who'd like to start with where it all began? Heather?
Yeah, I can help with that too if you want.
All right, Brian, you are Kevin. You go for it. You go for it. We'll come back to Heather in a moment.
Yeah. So in June of 2021, we had an outbreak at a rooming house in Hanover. During that time, there was a lot of people that lived at that place, that resided there, that suffered from mental health and addictions. And part of our work and operational group was to support that group during that time and ensure that they remain safe and keep them well for the period of time that they had to isolate for COVID. And so a partnership began between the County of Grey, Public Health, Grey River Health Services, CMHA, United Way, Salvation Army. There was altogether 15 agencies supported us for about a month, keeping those people safe with a lens of harm reduction, keeping them safe, responding to their needs around addictions and mental health supports, but also the wraparound social care. So through that month, there was quite a bit of improvement in health in the people that we were caring for at that time. And part of the exit plan, because we didn't want to just walk away. We've seen the difference that we were making, and the people that we were serving requested us to stay connected with them. So part of our transition plan was to reduce our number of days on site. To eventually, we moved our trailer out of the backyard and moved into a local church, and we call it the Market, and we operate that every other week in Hanover and every other week in Owen Sound. And that had the Market in Hanover started in that summer, and then Owen Sound came on in October. And then we were fortunate enough around Christmas of 2021, Ontario Health West asked us about doing some more work in this area. And we'd already been talking about gaps where we weren't able to follow up with people in between the market days. And that's where we came up with the mobile project, where we would be able to serve people in between the markets. So that's kind of it all in a nutshell. But
yeah, I know that I've talked to Dr. Era and Dr. Zayed of the health unit about this, and they were really quite pleased with the result, because you were able to address people's needs right there in time, and to use the phrase that, and maybe one of you can expand on this, the phrase you used, Kevin, and that's wraparound services. What are wraparound services?
Heather, you want to take that one? Or?
Yeah, certainly. So wraparound services might include things like providing primary health care, things that might traditionally be provided in a family physician or nurse practitioner's office, preventative health screening, infectious disease screening, routine wound management, those types of medical aspects of care, chronic disease management as well. We're primarily working with marginalized folks who aren't able or can't access traditional healthcare services. So going to where they are and meeting them where they're at, helping to meet their needs right in the moment. Might also include things like mental health counseling. Our mobile team is a group of 4 individuals who often travel together to provide medical care, mental health supports. Our CPs or our paramedics are also there to assist and can sort of extend the medical care that we provide. As well as we have a social navigator who works with United Way, who's able to meet the basic needs, attend to ID clinic, for example, and provide some of the life skills and peer support that is often needed also.
It's interesting you used an abbreviation there called RCP. And Kevin, you and I have talked about that. If I'm recalling the conversation on a previous show, I think that's a designation, is it not, for community paramedics?
Yeah, we refer to them as CP, so community paramedics. So it allows them to be trained in more of an expanded scope. And the traditional 911 response, they still retain that, but then they specialize in certain areas, whether it's chronic disease or again, Heather works in both areas, chronic disease with our CP program through home visits, but also in the SOS around the mental health and addiction support, the training that Heather gives them to be able to work under her to deliver that care.
That's interesting, because I don't think a lot of people realize that paramedicine has grown in leaps and bounds from just, as you said, a 911 response to working under the supervision of a nurse practitioner. That's really something relatively new. Is it new for you in your work, Heather?
It certainly is new. I've been working with this team now since January. Certainly, lots of familiarity working with other unregulated health providers, but I would say the collegiality in working with our community paramedicine staff has been outstanding. Lots of eagerness to learn and expand their skills and knowledge base, and you've changed some ideas about how we manage mental health and addiction in the community.
Sure. And I think that for those of us who have been raised in the traditional model of medicine, where the kind of where doctors are at the top of the pyramid and hospitals are the institutions in the community, this blows it all apart. Personally, I just was okay.
I'm really glad you say that. Yeah. So, I mean, I may function as a clinical lead, but I'm not in any way at the top of the hierarchy. Our mental health counseling role, our social navigator role, our paramedicine role, equally important, and each play a really important role in that wraparound service we're talking about. Without one, we're not the same.
Sure. No, I happen to know one of the members, one of your team, who is navigator, and she has Hear, Know, and Sound, and she has this really cool parka that says navigator on our system navigator on the back. And I'm thinking, that's different. That's different, very different. It's like I say, this blows up the model, the traditional model of medicine and medical care, which it tends to be hierarchical. And it sounds like what we're really talking about is a collegial system.
Absolutely. Yeah, without someone like our partner in social navigation, we wouldn't be able to achieve health card identification for individuals to access healthcare services. So it really is a very, very valuable part of the role.
Mm-hmm.
David, if I could jump in there, I recall back in, I think it was 2014, the community paramedic model was, Grey County was one of the few places that it was piloted here in Ontario. And I can remember being on council at the time, and it was a real paradigm shift, as you indicated, about how some of us traditionally have thought about as community healthcare, and it was so different that it just had to get support, and it did politically. And I'm really pleased to see that it has. I don't know if the right word is blossomed or not, but it certainly has expanded to do very much more than it even originally was thought that it might. So it's been a tremendous success, and it's one of those wicked problems in the community that we have a solution. It's not the only solution, and it won't be the total solution, but it is very much a solution. And you know, the paramedics in our community and all the healthcare workers do a tremendous job to look after all the citizens in our communities.
Mm-hmm. Indeed, and that's where the I think that we've got to get out of the 911 response paradigm. Where I live, I hear ambulances running back and forth all the time. In fact, I can even now tell the difference between one of your ambulances, a police car, and a fire truck. It's just, okay, now I'm attuned. But this is taking the whole model and bringing healthcare to people, as opposed to saying you must go to emergency or ER or every time you want to seek medical care. How has this had an impact on things like walk-in clinics, which we don't have here in Grey Bruce, at least to my knowledge? Heather, how has this new model affected that? Do you think we will see walk-in clinics on top of this kind of community paramedicine?
Well, I don't think the SOS mobile team is going to be able to fill the large gap of our lack of primary care providers and the current status of long waits in the emergency departments because there's so few places to go. For those who do have those added vulnerabilities, so those living, again, without primary care providers and homeless and or mental health and addictions, those kinds of issues, I do serve as the point contact for providing that medical care, continuing medications, and assessing and monitoring for ongoing conditions. We do have a great virtual care clinic that is helping to support individuals who traditionally might have to access Grey Bruce Health Services emergency rooms. Happy to hear that that's been extended. That does also help me provide my very narrow scope to those who really need it, who cannot wait for any number of conditions to sit and emerge for as long as is often required for medication renewals and whatnot. Also, we provide a significant amount of addiction supports with the mobile SOS team. So that pretty narrow addiction specialty is really great to be able to bring to the community, to the encampments, to our drop-in clinics that we run outside of our standard markets that Kevin has mentioned. So not quite a stopgap for our primary care provider or human health resources really across the board, but certainly able to support those individuals who I strongly feel probably need it most and are at greatest risk for having dire complications if they don't have their health needs met.
I just want to back up a little bit to something you've said, because that's news that I haven't heard yet or hasn't hit the media, that the virtual care that Grey Bruce Health Services has been extended, because I know it was supposed to end I think at the end of March. So if it has been extended, that's good news for everyone in Grey Bruce. I've personally used it a couple of times when I couldn't get hold of my doctor, and I would say it's excellent care. Glad to hear that it has been continued. So what kind of, you referred to addiction services. What would that entail? Do we still have a methadone clinic here in Owen Sound? So do you just support the ongoing work of people with addictions?
So I think Kevin gave a really great example. So those individuals at the rooming house who were supported, gained trust in the medical community and our social services that did provide care at that time, did want to stay with an alternate approach. Attending primary care visits or driving to our one RAM clinic here in Owen Sound. We also have them at other sites now, but at that time, I think it was primarily in Owen Sound. Our RAM clinic provides rapid access to addictions medicine, so that might include Suboxone, methadone, or Sublocade. Those are three options that we use. We basically provide a mobile version of that treatment plan. OATC and other methadone clinics do exist throughout the region, and that's always an option for individuals as well. So we really provide choice. Oftentimes starting folks on their recovery plan if it does include opiate agonist therapy or addictions treatment, but also supporting them to return to more traditional services or to go to inpatient treatment centers if abstinence-based recovery is a plan for them. Basically help them understand their options and support them in that choice.
I really like one of the things that you referred to earlier, and that is building trust in the system. That is a huge problem or challenge that people face if they've been abused by the healthcare system, and it happens, or they've felt rejected by the healthcare or not listened to by the healthcare system. So it sounds like you're beginning to again change the paradigm.
I really hope so, or a cog in the wheel. This position provides me that opportunity to be an advocate and to help other healthcare providers and social service agencies see another way to deliver service. And so far, I feel our clients, they're happy with their care. We haven't had fatalities within our own group of individuals who we've been following for addictions medicine during this opiate crisis. Doesn't mean it's not going to happen, but our wraparound approach to care really is a great example of how to do it well. And to, the stigma that still exists, of course, that is a huge issue, but recognizing the chronicity of an opiate or any addiction, relapse does happen. It is not a failure. And if we could approach addiction the same way we approach diabetes and other chronic diseases, folks would feel so much more comfortable accessing traditional health services.
David, I just want to say, just to step in for Heather here, because she doesn't really quite give herself or the team enough credit. The beauty of this team is that they go find you. They know where people are. They know their names. They've built the trust. Like these people are not coming to the healthcare system. We have to go to them. They, from whatever the past experience are, lack of trust, we reach out a hand and, try to help them in many means. And sometimes that means initially is something to eat, place to stay. And then we start talking about their health. And the thing I'm so proud of this team, like they truly do outreach. They're out on the street, they're walking the street, they're right where they need to be. They're not behind a desk like me. We need more people like them out on the street and doing the work they do. It's so important. Again, they're not coming to the hospital. They're not coming to a walk-in clinic. Like for us to connect with them, we have to be out and earn their trust, show them that we care and reach out.
And sometimes you mentioned a sandwich. Sometimes it's also just a pair of dry socks.
That's true. Dry socks, whatever it takes to help them, to get through the day. We're talking people with literally have nothing and barely the food for the day, or if they don't even have that, or the clothes on their back, they may be wet. Like those are kind of things that I see day in and day out. I have the privilege of hearing the stories of how they help people, and this team needs to be so proud. Like they wear that uniform of that yellow, and I've heard the term called street credit, and that's what they have. That color is street credit. They know that if they come to them, that they'll get help.
Sure. I think the other thing that people need to know is that it can be as simple as a pair of socks, and I know that a number of programs do collection of socks throughout the year. And if people want to help in a very tangible way, as one of the program people said to me, give socks. Give socks. And I know you can always donate socks to, in fact, Kevin, I'm quite sure that if we saw an ambulance and walked up with a bag full of socks, your staff would pick that up and say, yeah, we got a place for them.
Yeah, we'd figure out where to go, but definitely United Way looks after a lot of this, and they've been such a great partner. And I can't say enough of the investment of these like non-government organizations, of how much they give to this day in and day out. We've been meeting every other week since June of 2021, and we just had a meeting this morning. And every other week, we all come to the same table, we all talk, and we all, work on, making it better in the community. Like the SOS mobile team is a team of 4 organizations and public health as well in the leadership and development role. But the amount of support that goes into these markets between, like on top of United Way, like the Salvation Army and OSHARE the county itself, the housing department, social services, the why, the over every organization giving is unbelievable.
Now, Brian, I got a question for you now, since these two have kind of set the stage. What's the reaction around the county table to the SOS program? Because I know you guys, counselors operate at a very high level. You're concerned with dollars and cents and making sure the tax money is well spent, and you care for the communities who elected you, obviously. But what's the reaction of Grey County Council?
Well, I mean, it's always dangerous to speak for others, but I can tell you for myself, or what I perceive around the council table is an immense amount of pride, as Kevin said, in that whole collection of people that really do empathize with these people and really do care for the community and everyone in it. It really is a success story. It's easy. And I don't know if that's the right word or not, but it's easy to support financially a program like this because you really can see the results. You hear the stories, and by all means, I have not heard all the stories, but you hear some of the stories and you think, yeah, this is what it's really all about, making an impact in your community. And as politicians, there's a lot of, as we all know, there's a lot of bureaucracy in the world. There's a lot of talk. There's a lot of, as Kevin said, behind the desk stuff. But seeing programs actually work and make an impact, boy, that, as a politician, that really makes you fulfilled. It really does. And Kevin said that Heather doesn't give herself enough credit. I'll say that Kevin doesn't give himself enough credit too. Somebody's got to sit behind the desk, and I know Kevin's not behind the desk all the time, far from it, but somebody's got to sit behind the desk and pull the levers, pull the strings, and make sure it all fits. And by golly, he does it, because it's not easy, and he does a tremendous job of it.
Let me ask you, was this program a hard sell to the province?
Everything is a hard sell to the province at the get-go. But as they come to understand, and it's a matter, again, of making relationships, building relationships with your local MPP, the minister's staff, and all the rest of it, once they understand the impact that you're having, and it's easy to demonstrate, particularly here in our own community, once they understand the impact and they can see that there's value for dollars there, it makes it a lot easier sell. But right off the hop, yeah, everything's a hard sell because, to be fair, they're hearing stuff from all over the place, and there's huge demands on everyone's resources.
Now, politically, do you find that people jump to Toronto or larger centers as the way things are without listening to maybe success stories or other stories?
Well, there may be a default jump to that conclusion, but again, it's as I said, it's relationship building, and if you have those good relationships and you can demonstrate the good things that are happening in your own community, I like to think that any government is open to at least listening and giving you the benefit of the doubt as to how this can work.
Sure. It's in some ways an unsung or undersung but remarkable program. And Kevin referred to partnerships. One of the things I have in my background is a long history of what was called the partnership, which was an original arrangement or agreement between Hope Grey Bruce, Canadian Mental Health, and the hospital. And what this really sounds like is this has built on that arrangement. And I have heard it said, and I've said it on air before, that this area has a real reputation for doing some unique things that break the models. And the partnership was one, but this certainly sounds like another. Kevin, are you aware of any other areas where this kind of program is being run? Anywhere else in Ontario?
Yeah, but the one picture that we looked at was the home program in London. They have an inner city health with the community paramedics and different providers. I believe Waterloo and Heather Fergus Guelph area has a similar program. Yeah, there's different variations, but like the one thing is the complexity of this, service. We have an addiction specialist physician who works with an addiction specialist nurse practitioner. There's a community paramedic that works under her, and then the social navigation, and then the mental health that can do assessments to get you into treatment centers. Like it's a very sophisticated system. And what I find is if somebody is ready for treatment today, like with the team that we have in place, they can start. And that's quite often is you have to be ready in the moment. We don't have a day or two to wait. Like if they're ready, and they're ready for care, the team needs to be able to be available and responsive. And without that sophistication and that level of expertise, I don't think we could deliver that same type of service.
What it sounds like is that you are treating the issue of addiction, homelessness, mental health in a way that is, I would say, on a par with other serious illnesses such as cancer or a clinical emergency, appendicitis, heart attack, and saying you will get treatment. We will get you into treatment now. You want to go? We will help you get in there. Is that fair?
Well, we did some real good brainstorming about what our overall goals were, and our number one is to save lives at the end of the day. And that kind of is the 911 mantra, but this is really in the community under this work, even though we're not licensed sirens. But if Heather treats somebody today or under the paramedic and people, we get them on some sort of opioid agonist therapy, there's a good chance they won't overdose tonight.
And that is critical. I also want to come back to the statement that, and I think perhaps it was you, Heather, who said no one, or maybe it was you, Kevin, no one under our care has yet overdosed. And Dr. Ara said exactly the same thing in a recent interview, that the track record of prevention, or at least of reducing the risk, it's probably a better way of putting it, reducing the risk of overdose is significant through this program.
Yeah, and I think to I guess qualify that a bit further. So, there's overdose or opiate poisonings, and then comparatively the fatalities that may or may not occur based on that. So part of that is, I would say, in addition to what SOS has been doing together with our partners in public health, the doubling down of outreach, providing naloxone education and safer use supplies, things like clean needles, things like sharps containers, lots of education about the risk of mixing substances, because we really don't know what's in this toxic supply. And that's what we're attributing the big spike in overdoses we have seen in the last number of weeks. I mean, we've seen probably about what we typically see in half a year in just 2 to 3 months this year. So big spike, but people aren't dying, are not dying as often as they have in the past. And that, like Kevin says, is our primary goal, is to prevent opiate-related deaths.
Now, if we were to just take that out a little bit further, you referred to naloxone, and it is available free of charge in a variety of places. But there's something that goes along with naloxone, and that's training. Do you provide that training as well?
Absolutely. So we provide on-the-spot training. Our public health, together with a community paramedic outreach, went door to door to all the downtown businesses, offering them supplies and training as well, because that's one of the hot spots where these poisonings tend to occur. The public health often offers additional training, sometimes at conferences, sometimes at community events. Most of our paramedics have the ability to teach and train when they do respond to a 911 call. Our paramedics carry them all the time. A lot of our frontline staff, police carry it and have that ability to train. The instructions inside the kit's very, very simple to follow. They include gloves as well. Typically very low risk to the individual, and important to know that the Good Samaritan Act does protect an individual who is responding to potential overdose as well.
And I understand you can keep it in your glove compartment. That and cold temperatures don't generally affect how effective naloxone is. At least that's what Dr. Harris said. So I'll take his word on it.
Yeah, we used to keep the injectable. We use that far less frequently than we used to. It's a bit more sensitive, but the nasal, very, very easy to use. And again, if there's any asks, we are very happy to either one of our teams or one of our partners, CMHA, GBHS, and Public Health would also be happy to provide that additional training.
Okay, well, we've got to take a quick break, and we got to come back because, hey, there's a lot more to talk about. I'm David Shearman. This is Politically Speaking. We'll be right back.
This program is brought to you by Ignite TV. Now you're in command. Visit Rogers.com for more details.
I don't care what the law is. I will never be a slave. That word, I hate it. It rests on my tongue like rot.
Peter, how does it feel to get paid for your work?
There are rumors freedom's coming for us all.
Freedom, you know that's all I want.
Chloe, careful. Real men would rather sell you across the river to America than let you go free.
Then I'll run.
I've run before. Maybe this time for good.
No! No! Just get her into a boat. No!
Chloe! Chloe, no!
Word of Chloe Cooley's resistance led to Canada's first legislation limiting slavery. After 200 years, slavery was abolished in Canada in 1834.
Don't forget to tune in to Grey County Life on Rogers TV next week.
We're going to be talking to Emily B. about the ginkgo footprint and her peony garden.
Hi, and welcome back to Politically Speaking. I'm David Shearman. My guests are Warden Brian Milne of Grey County, Kevin McNab, Director of Paramedic Services, and Heather Prescott, who is a nurse practitioner with the Supportive Outreach Services here in Grey County, which is a remarkable program that we are talking about and getting to know a little more. Now, Heather, I have a question for you, which is, it's a kind of personal, but it's a direct question. How did you're a nurse practitioner, correct? And that means you're an RN, and you took additional training. Where would you have taken that additional training?
Yeah, great question. Thank you. So I was a registered nurse, graduated from Ryerson University, and then went back to do my combined nurse practitioner and Master's of Science at McMaster. Yeah, and since that time, I've spent the last almost 15 years only working with folks that aren't attached to primary care providers. So in my role with Grey Bruce Health Services for the last 11 years, I've worked with a number of chronic conditions, but seem to keep coming back to mental health and addictions. So that's how I arrived here.
That's really interesting because nurse practitioners have been, how shall I say, they're more common now, to be sure. But there have not been a lot of NPs with respect to mental health and addiction services. It's kind of like a subspecialty. What drew you to that and working with people on the margins?
That's a great question. I think historically, nurse practitioners have been used as sort of gap fillers, to be honest. We don't bill for our services. We're salaried through different mechanisms. So often things like these projects and programs, trials, we often get popped in to see how it fits. And that's always been great for me. I've always enjoyed being part of these startups, and I hope to make this a long-term commitment. So I started out working in long-term care, in working with dementia, particularly individuals who might be presenting to emerge frequently. And that has come up again and again in my career in trying to work evidence-based strategies for emerge avoidance or decreasing length of stay in hospital, all those quality markers that are important no matter where you are in healthcare. But it seems to often fall to the role of the NP, some of those quality projects.
And the reason I'm asking is that one of the things that I try to do is to lift up the various vocations that we encounter here on Politically Speaking, like yourself, like paramedics, to talk about some of these things that are people might be interested in. And with a new faculty of nursing or nursing school here at Georgian College, that's step one, because you have to be an RN in order to become an NP.
Yeah, that's right. And I'm trying to gap. It's been some time now, but the numbers of experiential hours required to then go back into your NP program. Exciting times, though. I was sort of born out of what was called a grow your own NP program at the time, where there were a lot of unfilled positions, just like now. And it appears as though NPs will also be included in that going forward. So there is some funding for individuals who may choose to stay in the community that they go to school in and become an NP and be paid to do so, which is exciting.
That's a really interesting idea, because one of the things I know about Georgian College is that the purpose of the program is to allow people to stay at home and to get an education, because nursing, as those of us who are baby boomers get older, we're going to need a lot of medical care. We can't live forever. So nursing is certainly a very interesting option for those who wish to get into that as a career. But as you say, there's more to it than just nursing. There is, you can go on to become an NP or specialize in certain areas as well, such as long-term care. And who knows, maybe eventually you could even become a paramedic if you wanted to.
It's true. That's true. Yeah. And in regards to working in the margins, nursing offers so many different subspecialties, as you mentioned. I've always preferred, I think, to work with individuals who needed that advocacy, the extra support to achieve wellness, and recognizing in my role as a nurse, maybe different than other professions, that helping service. Being that adding the care piece and really being able to offer that holistic level of care. That the scope of the NP is so broad now, there's very little that I can't do in my practice that would be offered elsewhere in the community. So it's a really exciting time to move into nursing and perhaps consider expanding.
Sure. And I'm sure that anyone who was, any of our young people who were interested in nursing and the role of an NP, I'm sure you would be great to talk to if people wanted to contact you.
Yeah, and I have an NP student currently, which is exciting. Yeah, teaching is an important part of the role also. Yeah, he's not in the room for this, but we have an NP student currently.
Well, that's
my
great.
Daughter wants to be, my daughter wants to be just like Heather. She's actually, that's her goal, is to be an NP and work with mental health and addictions. So she's like, when you ask her what she wants to do, she wants to be like Heather. So.
Wow. That's actually quite encouraging, because one of the things I have learned over the years in my time in this community is that we have a chronic shortage of mental health and addiction workers. It takes a special kind of person. I'm sure, just like to be a paramedic, Kevin, it takes a special kind of person to be a paramedic. But it also takes a special kind of person to work in the field of mental health and addictions. So if young people are interested in that or curious about it, it's an area that is certainly worth expanding and exploring. And apparently the government is throwing more money at it. So let's hope that you're able to do your job and get more money for this kind of thing.
Sure trying. One of my daughters is a nurse as well, and we need all the help we can get.
And it's going to be an exciting time to come into the field with the opening of the, I'm going to call it Bayview. I'm not sure it's been named yet, but we've all been calling Bayview with one of its, the first facility of its kind in Canada. What an exciting time to come into the mental health and addictions field.
Yep, for sure.
Yeah, I was going to ask about that. Is there any dovetailing between your work, Heather, and the new Bayview Center?
Yeah, absolutely. I would say the new Bayview Center, as well as the new supportive housing unit going on at 14th Street also. We have incredible linkages between our RAM, or withdrawal management support services that exist currently, which will be moving to the new site, as well as our intensive case management, our assertive community treatment center. All of those types of services dovetail really lovely with a lot of the clients we see. There's a lot of overlap. As far as our short-term emergency housing folks that are then transitioning into permanent housing situations. It's always lovely to see people progress. It's not always about the health aspect. Folks in recovery, any aspect of recovery, able to maintain and maintain their housing is an incredibly important fact. That housing first model is something I strongly support, and we see it all the time, that individuals with shelter have much better outcomes and are able to access services.
Yeah, which leads me to another question, Brian. I noticed that the province has actually given a lot more money to social services just recently, and what was surprising was that it was a kind of a backdoor announcement. It was there, and then nobody made a big deal of it. But it is a big deal.
Well, and it certainly is in our community. Any support financially just allows us to help more people and do a better job. I can't speculate on, why all of a sudden or where, but it was well received, and we're very appreciative of it. Listening to Kevin and Heather, it's very easy to feel upbeat about how much we're doing and how well we're doing, but it's almost like taking a pail of water out of the ocean and thinking, yeah, we got a really good pail of water here and we're doing a great job, but holy mackerel, there's a lot of water in the ocean. It is a huge problem, and for some, myself included, it's almost a little bit overwhelming when you think about the problem and what could be done. But you have to stay focused on what we are doing and what we can do. We can only do what we can do, and it feels better when you think about it in those terms.
Good point. And I'm just thinking that with the three of you, you've really got three unique areas of emphasis. I mean, Brian, you've got the political emphasis, which is absolutely essential to continue to get the government's attention to this issue. Kevin, you're dealing with a lot of the administrative stuff with paramedic services and making sure that that's well provided. And Heather, you're dealing with the kind of front-facing program, and it's not one or the other. It's all three of you working together to see for the benefit of the community.
One thing I can say is also, since I've been here in these roles, and I've been here since 2004, like between council and our senior management team, our CAO, Kim Wingrove, like our goal is to help people, and we've always been so well supported. As long as that's our focus, we keep that in our eye as helping somebody. Like we are able to do these programs because we are supported, from the top down, bottom up. Like we wouldn't be able to do it if we didn't have that support.
Yeah. True. Now, Heather, you spoke about some of the people who some of the components of the wraparound services, and one that was really interesting that I've heard again and again is identification to get a health card. Many people take it for granted. Well, you got the green card, and the Premier has said very strongly, we'll never have to use our credit card. We will always use our health card, but there are people out there who don't have them.
Absolutely. And getting that card is very difficult. So if we go back to during COVID, the rules changed temporarily. to allow individuals to receive OHIP insured services without being charged if they didn't have a valid health card. As of April 1st, that's changed again. We haven't seen the ripple effect of that yet, but the idea of some of the folks that we follow that do not have ID, say folks from the rooming house that had a fire that still don't have ID. You need 3 pieces of identification to get a new health card, for example. I don't know where my birth certificate is. So I can only imagine, I see it every day, how some people struggle to achieve those requirements to get a health card, to get a bank account. You need those things in order to get tenant insurance, to get yourself an apartment. The ripple effect is enormous. So I do have concern, given our lack of walk-in clinic and the fee models that might exist for individuals to access care in emergency rooms. If they have no address, I guess it's going to be hard to bill them. But if individuals believe that they might be charged for services in the ER going forward, they may be less likely to attend and receive timely health care, which will only then lead to more complications down the road. Individuals with health cards will quite likely not able to see specialists. They won't be able to have any virtual medicine care, laboratory testing, diagnostics, goes on and on. It's quite concerning. We'll have to see what happens next, but there are some agencies that are really stepping up and trying to push the government to make a change, provide healthcare for all. And given that most of these individuals that I care for in this difficult predicament, I'm certainly in their corner and happy to provide that advocacy as well.
Mm-hmm. And it's not because of a lack of anything. It's just it may not even have existed in the first place, or if it existed, it's disappeared. I know that for people who are living on the margins, theft is a huge issue. You may wonder why someone's trundling a buggy full of stuff around town, because that's where their stuff is, and if they don't have it with them, it's likely to get stolen. So, and that goes for ID as well.
Absolutely. So, it's not uncommon for folks to be very proud to show me their updated health card version code, to not have it at the next visit because it's been stolen again. Yeah, a real headache, and seems to be a nuisance, and I'm not sure it's a necessity. I mean, that's at a level above me, but at the front line, it seems to be a huge barrier to care. Yeah.
And even something simple like the fee for a birth certificate. I think it's $35 or something.
45.
40. Oh, it's gone up.
Yeah, and these things that I until I took a role like this, I had no idea what the barriers were like. A nurse practitioner, again, just doesn't bill the same way a physician might, but it might fall on the shoulders of physicians who bill typically after the visit with their clients. Is the expectation that they take the hit every time they see an individual but don't get paid for it. That doesn't seem fair either. But yeah, multiple barriers. And if you don't know if you need a birth certificate and you happen to have some of that information, maybe you do have your $45. If you don't know your maiden name of your mom and all those where you were born, those are other things that can take months and months to get a health card.
Yes, absolutely. Well, I don't think we realize how much privilege we actually have when we have that little piece of ID. And it is privilege, because a lot of people don't have it, and it's through no fault of their own, and they are entitled to health care.
That's right. That's right.
So, well, it's that ID, providing that ID is a huge issue. And I remember encountering this we encounter this on every election. People don't have the adequate identification to do something like voting, so they don't vote. So it's an ongoing thing. Brian, there's another thing for you to work on.
Well, I was just going to say, in another organization that I'm involved with, outside of politics, so to speak, the program that Heather was talking about there was a period of time, as she indicated, during COVID, where you didn't need to provide a health card to get service. The numbers that I saw, financial numbers that I saw, that come out of that particular program for the one institution that I'm familiar with, really were very low. And if if we really want to drill down to dollars and cents, the long-term implications of those people not getting health services at the get-go of any kind of problems, they just multiply down the road, right? As Heather indicated. So in my mind, let's not worry about somebody's got a card or not. Give them the services they need healthcare wise, and let's save ourselves a bucket of money and provide the person with the healthcare they need. It just makes a lot of sense to me. And given the size of, provincial budgets and all the rest of it, I'm not sure it wouldn't even be a rounding error. So this obsession with making sure that, and I hear from time to time people saying, oh, I think we should charge people, pick a number, $10 when they show up at Emerge. No, that's just not on, because as Heather indicated, people will not show up then just for that barrier. But we need to get them in front of a healthcare professional to deal with the issues they have earlier instead of later. And so you're right. That's something that I will and have been trying to preach to anybody that will listen.
Okay. Well, Heather, this also raises a question about ongoing care as an NP. Do you see, and in the SOS clinics, do you see people for ongoing management, let's say for diabetes? Do you help them with that ongoing management?
Yeah, there's times where it's appropriate, certainly. Again, I'm working with that marginalized group of individuals, which, 1 in 3 healthy individuals will have diabetes in Ontario. So it definitely comes up frequently. I worked in diabetes education and was an educator for my years prior to coming to this role, something I'm very, very confident in. So absolutely. The long-term goal, of course, is to connect folks to the very long healthcare connect, get them on the list for a doctor in our region. There are times where I can find a more appropriate provider, such as at our CHC, if they're in that region. Our CMHA and Brockton Family Health Team NP does take folks that sort of we service as well. They're all full right now. So we don't have, it's a bit of a bottleneck situation. So sometimes having to use the virtual care clinic for renewals, but there are individuals that I will follow with the intention of it being short-term, but recognizing, taking my head off the paper, that there's going to be some time that I'll need to follow them. Yeah.
So it's a both and, not an either or.
Yeah, yes, I'm afraid so, as so often is in this role. Yeah.
It sounds like what you need to do in your role needs to be, you need to have flexibility, openness to change, and openness to potential situations that may be so far out of the box that you never trained for them.
Yeah, and that's what's so exciting about this opportunity. I know that would scare some individuals away, but that's just right up my alley. I quite love that about this job. I've provided diabetic care in a tent in one of our local parks, for example. Like, who gets to do that? Of course, much prefer to see someone housed, but to be able to meet that need in the moment when they need it is just so exceptional. It's a really great opportunity to meet folks where they're at day in and day out.
Sure. We're so fortunate to have the relationship with Graybridge Health Services. Like, Heather is with us full time now, and she started with SOS and working in that role, but she also works with our community paramedic program with our chronic disease patients, typically that are elderly. So she helps with the patients that are unattached and they don't have primary care. And so she's not only doing the SOS front on the street, but she's also, taking calls from our community paramedics that are working with an elderly person with diabetes and supporting them. So we're very fortunate to have Heather in all her experience and in both these roles.
Well, thank you for raising that, Kevin, because the community paramedic service, with patients, visiting patients in homes is another aspect, although not supportive outreach. It's another aspect of paramedicine that we've piloted here in Grey Bruce, and I know people who have used the service and who are patients in the service, and they love it. It really does make a difference, particularly in rural areas. So it's good stuff.
Yeah, we've been fortunate to, like the program has expanded. At one time, we'd have around 130, 140 patients. Now, at any given time, we have between 350 and 400. And we branched out now and working with the palliative physicians and offering palliative care in the community. And then, recently, again, with Heather coming in, without the medical professional to delegate to the physician, we're limited to what we can do. But when we have somebody like Heather or the physicians that with the oversight and the delegation, we're able to provide these expanded skills in the home and treat people in their home and keep them out of the merge.
Mm-hmm. Mm-hmm. So it would be fair to say that medicine is changing. Community medicine is taking us down roads we probably never thought we would go down. The opportunities seem absolutely phenomenal, both in paramedicine and in nursing.
I believe it's a team approach. Sure. It's nursing, it's NPs, it's physicians, it's specialty physicians like palliative physicians, it's like paramedics, but it's also bringing in like the counties and the supports of the county and the social services. Like we always think that we're most important health, right? And we sometimes feel that way, but I learn more and more that without having these other basic needs met, like housing and food, if you can bring all the health you want, but you need to have it all. It needs to be working together and be one group working together. We call it integrated health, everybody working together.
Sure. And what you're describing, Kevin, is what at a very high level is called the social determinants of health. That's language that we should hear more about. That things like housing, things like jobs, things like medical care are all parts of us being part of community. So it sounds like this is one program that is doing a lot of that and doing it quite well.
I agree. I keep the wheel on my desk.
And that places a little obligation on you too, Brian. I mean, we've got about 2 minutes left, so I just wanted to, maybe give you the last word as the warden. You must feel good when you see programs like this.
Well, as I said earlier, it really does give job satisfaction. It really does. I mean, it's very fulfilling to see programs make an impact, make a positive impact, and it honestly, it really is easy to support programs like this when you see the quality of staff like Kevin and Heather and others that are making this program work, and they're so passionate about it and they're so good at it. You can't help but say, what do you need to get it done? And we'll move heaven and earth to get it to you. And there's so much of this job that is just absolutely stuff, but things like this really make it worthwhile, and really make it worthwhile getting up in the morning to support people like this. These two that just they're just so connected to the community, and it's true. It's a team effort, but they're the ones that are the wheels on the ground, and well, except for the wheel that's on Kevin's desk. But they're the ones that make the wheels turn, and it's really heartening to support programs like this.
Okay, well, I want to thank the three of you for being a part of Politically Speaking. Warden Brian Milne, Kevin McNab, Director of Paramedic Services, and Heather Prescott, Nurse Practitioner with the Supportive Outreach Services. Thank you, all of you, for being a part of Politically Speaking. And friends, thank you for being a part of Politically Speaking. We will talk again. I'm David Shearman. We'll be back.
Call the Rogers TV Viewer Response Line. Email us or connect with us on social media.
Are you the type who would keep going or stop? It's not easy to stop when you have an addiction. Legalizing cannabis won't stop addiction. It trivializes its consumption. Let's be vigilant. If you need help, visit portage.ca.
Calling all journalism students. Omni Television is once again awarding scholarships to qualified students pursuing a career in third language journalism.
The Omni Scholarship has been